Good afternoon again. Challenging presentation because we had a very good presentation yesterday about SGLT2 inhibitors, abundance of good quality medicine. Challenging to talk about again, but I hope you enjoy it because it's a different approach to the same evidence. So evidence is there, everybody knows about it, everybody is convinced about it. We are going to highlight some parts of this evidence, but it's how you look at this evidence-based medicine. Okay. Sorry. So it's called the Understanding the 360. I like the title, 360 degree concept, looking at the disease as the cardiometabolic and renal disease. I'm sure after this presentation, everybody was thinking about the renal protection, cardiorenal protection. Bariatric surgeons will think about mainly the metabolic improvement, about the obesity, about the fatty liver, about the visceral adiposity. Cardiologists will think about this, but you will just see that these three parameters are interrelated, interlinked. A small change, a small disturbance in one of them will trigger a response in the others. So if you want to achieve the best outcome, if you want to eliminate the residual risk that we showed yesterday in your patient, despite being on optimal treatment, standard of care, and you add medicine, you have to look at your patient in this 360 approach. Okay. We said, so cardiorenal metabolic approach takes into account that any change in these organs, whether it is acute or chronic dysfunction, can lead or can stimulate neurohormonal, immunological, and biochemical pathways in the other hormones. We all know that diabetes is a risk factor for both kidney and renal disease. Just looking at it in a closer way, we know that type 2 diabetes by itself reduces the life expectancy by itself, and adding chronic kidney disease and or heart disease will further reduce your life expectancy. We also know metabolically that half of our type 2 diabetic patients have non-alcoholic fatty liver, and half of the patients are obese. More than 80% are hypertensive patients. So the metabolic syndrome is there, and you have to address that as part of your holistic approach. I mean, even this holistic approach resulted in even change in guideline. Now the ADA is talking about remission. They have criteria for diabetes remission, partial remission, complete remission. You are not talking anymore about diabetic control or tight control. You are talking about remission according to the latest ADA guidelines. So I think the only way to achieve this, other than bariatric surgery, is looking at this and try to tackle this from these 3 points of view. I'm going to show that our SGLT2 inhibitor, the EMPA, is looked after all of this, and we have good quality evidence base, which I'm going to share with you soon. Again, why chronic kidney disease and heart failure, coronary artery disease? Because they are very frequent and common, and basically they are the first cardiorenal manifestation in type 2 diabetes, in addition to the other cardiovascular risks like stroke, MI, peripheral artery disease. Chronic kidney disease and heart failure are the first and the most common presentation in these patients, so you have to definitely take care of those. And they are the major cause of mortality as well and morbidity. We mentioned this, a diabetic patient by himself, almost 1 in every 3 diabetic patients have coronary artery disease, whether clinical or subclinical. They are at 2 to 5 times higher risk of developing heart failure. And as you add cardiovascular disease to diabetes, you reduce the life expectancy, as we mentioned. This is exactly what I am saying. So diabetes will reduce your half-life, life expectancy by 6 years. Adding cardiovascular disease or chronic kidney disease will further lower your life expectancy by another 6 years. Again, the same with chronic kidney disease with cardiovascular disease. We know that 2/3 of patients with heart failure, they have coexisting chronic kidney disease. And the risk of cardiovascular death increases among those patients. And even chronic kidney disease and heart failure increases the mortality by almost 30%. The graph shows this very clearly. As your kidney disease and diabetes advance, till you reach albuminuric and reduce EGFR, you significantly have a 47% increase in your relative risk of mortality. What can we do about it? We said you have to look at it from these three aspects: the metabolic part, the cardiorenal. Yesterday and today we're going to talk about the renal and cardiorenal syndromes, but it is important to look at the metabolic part of it. Yes, guidelines say, regardless of the baseline HbA1c, regardless of the target, but there is no chance that you have to ignore this. We have to handle the glycemic control. We have a lot of evidence that you have to handle it, and this will improve the outcome. So how Jardiance or IMPA can affect the metabolically in your patient? We have good evidence from the IMPA that you will achieve a reduction in HbA1c from 1.18 to 1.4% from baseline. This is clinically significant. Just keep in mind, I mean, this is important clinically, this HbA1c reduction is dose dependent. So what I see in practice, most of the patients are on the 10 milligrams of Jardiance and they are happy. If you can, and there is chance, just upgrade it to the 25, because we have evidence that the higher dose, the more HbA1c reduction. Don't be resistant to use the higher dose to maximize your oral therapy patient. What about weight loss? Yes, you can achieve from 3 to 4.5 kg weight loss. And again, this is dose dependent, as you can see. When you use the optimal dose, the 25 milligrams of empagliflozin, you achieve better weight loss than the 10 milligrams. And just mind you, in the sub-analysis of this weight loss was real. This was not water, was not fluid, was not polyuria. This was visceral fat. They have checked that in DEXA scan. So this 5 kgs, they are real visceral fat. This is real, genuine weight loss of visceral, of the bad fat that you have, which will translate later on to improved metabolic outcome. Again, you have data on blood pressure, systolic reduction, improving in lipid profile, and as I mentioned, in reduction of visceral adiposity. So you have clear evidence with IMPA that you are metabolically attacking these targets together. IMPA-REG is one of the most important, initially meant as a cardiovascular outcome trial to ensure safety of the drug, but it revealed much more than safety, morbidity, mortality benefits. I'm going to share some of this with you. So it's a study, initially I think around 11,000 patients, according to the inclusion criteria. They ended up having 7,000 patients from 42 countries. They followed these patients for around 3 years. Primary outcome was cardiovascular death and fatal, non-fatal MI. And we'll see important, just focus, this, they use the 10 and 25 milligram against placebo. Somebody will not like it, but this is the requisite. You want to make sure that this drug is superior and safe. So in this study, both doses were used and against placebo, and the follow-up was around 3.1 years. Here, so the majority of patients, 3/4 of the patients were already having established coronary artery disease. And 25% they did not have this. Some people criticize this. They said you are using a very high-risk patient from the beginning, those with established coronary artery disease. The outcome, this is not the patient that you see in the clinic, which is mild to average risk without an MI. I disagree with that. I think this is something useful. This is a study with a limitation. You have time limitation. You have to prove that there are some events, and these events are more common in those high-risk patients. And even later on, when you compare it now, you can compare it with the placebo. You can compare with other new agents like the GLP-1, which was studied in the same very high-risk age group. But thankfully, we have a real-life extension of the IMPA-REG, which looked at this data across those patients who don't have established coronary artery disease, but they are high-risk patients. So you can see that this result applies to both continuum, those with established cardiovascular disease and those with just high risk and they don't have initial heart disease from the beginning. I mean, what can you see more than this? Amazing results, amazing because they are impressive, amazing because they are early, amazing because they are sustainable. The 3 yeses. Is it amazing? 38% reduction of cardiovascular deaths, which is the commonest cause. Half of your diabetic patient will die from cardiovascular disease. You have 38% reduction in cardiovascular death. You have 35% reduction in hospitalization for heart failure, 14% reduction in major adverse cardiovascular event, and 32% reduction in all-cause mortality. Impressive, yes, impressive, but just notice the separation, how early it starts. You don't need to wait 7, 8 years to get these results. You will find these results just from the beginning of the study. And these results are not just impressive from the beginning, they are sustainable throughout the study. And so you don't have to wait long time to achieve this amazing result. And you don't actually, I'm going to show you in the next slide, you only need to treat 25 patients for 5 years to have these amazing results. You don't need to treat hundreds of patients to achieve. So you achieve great results early, sustainable, and with a small number to treat patients. So there is no more convincing evidence that the class, the SGLT2, and especially in the EMPA-REG, the empagliflozin, has a very impressive effect early and among patients. Already, just you can look at that, you only need to treat 25 patients to prevent one death. Those patients already are on maximum standard of care. Most of them are on ACE and ARBs and on statin and antiplatelet. Despite that, you are achieving mortality benefits in these patients. Again, this is a graph showing that it is a class effect with some members, little bit, some more effect. But again, you can see all of the SGLT2s and GLP-1, majority of GLP-1 like the liraglutide and the oral semaglutide crosses the line and shows cardiovascular risk benefit. What about renal outcomes? So the data that you see the impressive cardiovascular. There is no doubt that you are going to benefit your patient from the cardiovascular, benefiting your patient early, benefiting your patient in a sustainable, and benefit your patient, even treating small number of patients, you will achieve benefit, cardiovascular mortality benefit. What about renal function? Yesterday we talked about the class effect renal function of the SGLT2 inhibitors. It is reproducible here as well. You can see that new onset worsening nephropathy, progression of kidney microalbuminuria, progression to kidney failure, time to dialysis, the line is crossing to the left side, showing beneficial effect. This is in details. You have 39% reduction in all composite renal outcomes. New or worsening nephropathy reduced by 32%. This is very important because a lot of my colleagues, primary care, cardiologists, nephrologists, they think this patient is an elderly patient. If we start SGLT2 inhibitors, will cause more dehydration, will cause volume depression, more renal failure in such patient. I'm afraid to use it. Already GFR is borderline. If I use the SGLT2 inhibitor, I may cause acute renal failure. I may cause worsening nephropathy. I don't have the slide, but it's there. It's not only that there is no difference initially between other than the small dip. I'm going to show you the small dip, which is sustainable in renal failure. Actually, the study showed that it is protective against new onset renal failure. So don't be scared of using this patient in a nephrology patient. Dr. Mohammed talking about Ramadan, risk of volume depletion, risk of hypoglycemia. There is no risk, but again, you have to instruct, counsel your patient. You have to initially tell him that you are going to increase your visit to the toilet. You have to compensate that with water. If you don't do that, or if you have an elderly patient with hypodipsia or without access, you are having the risk. But don't be afraid about the risk of acute renal failure. No, studies have shown the opposite. If you use it, you will prevent acute renal failure in such patients. What about progression from microalbuminuria to macroalbuminuria? Yes, you have 31% reduction from microalbuminuria to macroalbuminuria, doubling serum creatinine reduction by 42%. Amazingly, reduction of 50% of initiation of renal replacement therapy and dialysis. You are giving your patient 50% chance of living dialysis free, and you know, all of you, what quality of life for the patient and for the family once they reach dialysis and they are waiting for renal replacement kidney. So it is safe, the message, it is safe, it is beneficial in the whole range of the kidney spectrum. Again, don't be scared of this. Be aware of it, the initial dip which happens with the first 2 to 4 weeks of the use of the SGLT1. Again, few things. Don't be scared because not all of the patients will dip. You have 30% who are non-dippers. 60% will have initial dip. 30% will not. So not all of your patients will have increase in their creatinine or they will dip. The second thing, keep in mind, this dip is dose dependent. The higher the dose you can see it in the graph clearly. The red one is the 25 milligrams and the 10 is the 10 milligram. You have more dip with the higher dose. So if you are afraid, just use the smaller dose, that's fine. If you are confident that your patient have access to water, and this you can use the maximum dose of this. This dip is initial, and then it maintains to another set, and it protects the progression of the kidney disease. So don't be afraid. This is just something transient, and rarely you have a patient with a dip more than 20 to 30%. Majority less than 10%. Very transient, and it will go up. Watch your patient for the first two to 3 weeks. Yes, for the increase in creatinine, 10 to 4%, or reduction in GFR for 10%. Majority, I mean, I told you, 30% will not dip, so headache-free. The other 2/3 majority will have a less than 10% dip. Don't be scared, use it, but follow your patient closely. Again, this is a beautiful slide showing that whether you have normal albuminuria, whether you have microalbuminuria, whether you have macroalbuminuria, your kidney function is sustained regardless of your eGFR is maintained compared to the, as you can see, the placebo, which is declining over time. Whatever your initial albumin creatine ratio or excretion, your patient will benefit in sustaining kidney function over time through the whole range of kidney disease. So this is, I mean, there is nothing more convincing than this. EMPA, as we said, the study population in the EMPA reg was 75%, those with established cardiovascular disease. Somebody will say, maybe this is not the patient that I see in my clinic. I don't see a patient with cabbage. I see a patient, an average diabetic patient, diabetic, hypertensive, dyslipidemic. This study might not apply in real world population. They extended this into a real world study to look at those group with established and those with just high risk without. Does this protection apply to those as well? Answer is yes. And it's nice also because it is a real world study, so you can compare. In the study, they compared the medicine with the placebo, the 10 milligram, 20 placebo. Here we have some, you can compare it to the other drugs, head to head, to the DPP-4s, to the more interesting one, to the GLP-1. You want to know which one can have more benefits, and they have done this in the EMPRISE study. They compared real-world data, comparing head-to-head between GLP-1 and SGLT2, the EMPA, and with DPP-4, and it's clearly, I don't going to go through this, show you that comparing with DPP-4, it showed superiority. I'm going to show you this, sorry. This second. Yeah? It's got stuck. Again, comparing with DPP-4, you have 44 relative risk reduction in heart failure patient. Comparing to GLP-1 receptor analogs, you have 26% reduction, relative risk reduction. So these results are not only for those who are in the EMPA-REG, the established coronary cardiovascular disease, even those with high-risk patient, diabetic, dyslipidemic, the average patient that we see in the clinic, the results apply, and they have all the benefits and the protection, especially the secondary protection among these patients, and you have a lot of benefit, renal benefits, cardiovascular benefit, no doubt, early and sustainable, and the kidney benefits through the whole range of patients that you see. Initial patient, those already achieved in the macroalbuminuric phase, they are helpful. You can prevent the decline in their kidney function test. I mean, that's surprising. We have a lot of amazing evidence, quality evidence. We need to translate this into real practice to help the patient. Thank you.